Hello, my name is Dr. Jeffrey Barsuk. I am the Robert Herstick Professor of Medicine and Medical Education at Northwestern University Feinberg School of Medicine. I currently serve as the Executive Medical Director of Northwestern Simulation. I would like to welcome you back to another podcast in our series on simulation and healthcare education. Today, we plan to highlight Chapter 7 on implementing and managing a mastery learning program in our book called Comprehensive Healthcare Simulation, Mastery Learning, and Health Professions Education. Today, I have the distinct honor of interviewing Dr. Kenzie Cameron. Dr. Cameron is a research professor of medicine, medical education, medical social sciences, and preventive medicine. Kenzie, we've been working together for a long time, and it's awesome that I get to interview you today.
I'm thrilled to be here, Jeff.
All right. Well, we usually start off our mastery learning podcasts by talking about your background and your training and how you started getting involved in simulation.
Great. Well, my background is in communication. So I am a PhD trained researcher in communication with a focus in persuasion, social influence, health communication. And I've been here at Northwestern since 2003 because I learned that I really wanted to be involved right at the base of medicine in an academic medical center in the research that I was doing. And I'm now a health services researcher in the Division of General Internal Medicine and Geriatrics. In terms of how I got involved in simulation, well, I have you to thank for that. It was about 8 or so years ago where we collaborated on a project that was related to central line associated bloodstream infections. And we were seeking to disseminate the curriculum that you had created to hospitals all across the Veterans Administration system. And so I've been working with you and the team ever since on that project, on other projects, and we just keep going.
I also know that you have a master's in public health. Can you tell us a little bit about that and how that shaped your career?
So I received my MPH here at Northwestern after I already had my PhD. As a matter of fact, I was both teaching in the program as well as being a student at the same time. But I decided to do the MPH program as part of my Center for Disease Control and Prevention K Award because I really felt I needed to walk the walk and talk the talk of academic medicine. So I was coming from social science and there was a lot of overlap, but there definitely was a lot more I needed to learn. And the Master of Public Health enabled me to do that.
But I want to take the time now to kind of discuss the chapter that you were a co-author on, where the chapter discusses key features that are required or need to be thought about for implementation and managing a simulation-based mastery learning curriculum over time. So can you talk about some of the things from the chapter?
Absolutely. And in the chapter, we cover a number of different elements. The first 3 I'd really like to start with are thinking about the team, the time and the timeline, and the resources. So the team is so incredibly important. We're fortunate here at Northwestern and with the many colleagues we've worked with across the country and for some of us across the world, to have an amazing team. But what's important about the team is who do you need on that team? And as a matter of fact, that's exactly how I became involved with all of you. You wanted some additional communication perspective, and then you also knew that I had qualitative methods background. Other important parts of the team, important people on the team might include videographers and sound designers, because so often we're creating videos or products that we then are using as part of our curriculum. Of course, you need the scientific expertise, the clinical expertise. You need someone who is there day after day managing the program, knows the ups and downs, knows the lumps and the bumps, and you need the oversight. And so there's so many different elements and parts of a team, but we wanted to stress in the chapter just how important it is to think beyond perhaps a team that you often think of for research, to think about more of the day-to-day implementation, these aspects such as sound design or art design and additional methodological experience.
When you talk about the team, I couldn't agree with you more, obviously, because we were on the same team. But one of the key features for me on the team is getting involved with diverse people. The more diverse the team is from different backgrounds, I think the more successful the team is, and it allows you to think out of the box. But also team members that are very committed to the project, because we know people have competing interests. And if someone can't devote the time to reach a deadline for the team, maybe the team is best served by having someone else. But I love the fact that you're talking about the team, because the team is everything, and the team dynamics and how people get along and how they do their work together is what I think has made our program successful.
Yeah, I would agree wholeheartedly.
All right, I'll let you move on.
Okay. Well, and you actually mentioned the time and the timeline. And, that is something that's really important to consider, because, of course, everything always takes longer than we perhaps want it to, or maybe even have budgeted for in our own heads. But so it's important to kind of think through what time is needed, what are the actual logistics, does the team leader have the time to oversee the management of the project? Do they need a right-hand person to make sure that that happens? We have to think of time estimates for things such as sessions for learners who don't initially meet a mastery standard. And so even if we say we have a curriculum that takes approximately 8 to 10 hours of time, we need to also budget and plan for those learners who perhaps might take 14 to 16 hours to get to mastery. If we're working with standardized patients, of course, we need to think about budgeting for their time as well, both in learning their role, in learning any assessment that they may be doing, and then in actually performing as the standardized patient in the process. Another aspect is resources. And so this includes facilities and equipment. I mean, I just mentioned standardized patients. If you think about it, if you're going to have standardized patients interacting with a learner, you need a place to do that. Do you have the clinic space or the educational space that you're able to use for the amount of time that you need? Are you using a classroom? Are you actually using a room in a clinic? Or are you fortunate, as we are here at Northwestern, to have a simulation center where we can make that happen? Sometimes the curricula require advanced equipment and supplies. We might need high fidelity patient simulators, computers, perhaps even cadavers, which might then require a specialized space. So it's important to think through these many different aspects of a project before you begin to implement it. And you also need the time to be able to, kind of make sure, are we on track? Are we on track with our timeline? If we're not on track, why? Is it something that we need to rebudget our timeline and therefore maybe our resources? Or is there something we can do to be more efficient with the time and resources that we do have?
I would add a few other key things
Sure.
that I think were mentioned in the chapter that are also mentioned in the chapter on return on investment. And specifically, that's ensuring the support of the stakeholders. And certainly the stakeholders can be multiple. For many of our curriculum, the biggest stakeholders are our residents and our program directors for the residency and our faculty that teach the course. But also you can think outside of that box, that internal box, that though there are maybe other stakeholders for your curriculum. When we disseminated it to the Veterans Affairs Hospital, there were a lot of other stakeholders, from government officials to VA officials to everyone that was touching that VA. And ultimately, we can't lose sight of insurers as potential stakeholders, as well as maybe the most important stakeholder, the patient.
Absolutely. And I'm glad you mentioned that, because that goes beyond the team members that I perhaps was listing, but stakeholders can be an important part of the entire process. Some of them may be incredibly engaged and part of the team, but it's important to move beyond that, as you said, to make sure we're getting perspectives outside of the box that we're living in and looking forward to the implementation of a project. And in fact, you noted our work with the VA. This might be a great time to kind of transition to this idea of what can you learn when you start talking to people about how is the curriculum going? What needs to be in the curriculum? Is it meeting the needs?
Right. So let's tell our listeners a little more detail about the VA project. So we had the fortune of taking our central venous catheter simulation-based mastery learning curriculum that we had implemented at Northwestern Memorial Hospital in Chicago and showed translational results showing that it positively affected patient outcomes. The VA was interested in a program that they could use to train their clinicians across the country on how to insert central venous catheters. And the timing kind of just lined up right. And we obtained a contract and a grant to essentially go to 126 site visits to train the trainer on how to use our curriculum. And one of the aspects of that is we wanted to evaluate the implementation process. So we were able to ask the trainers and other personnel in the VA that were involved in the care of central venous catheters about barriers and facilitators to central venous catheter insertion and how those barriers and facilitators would inform our curriculum. So tell us about that, because we went to a lot of VAs together. We traveled a lot.
And part of what we were interested when we visited these VAs was talking to those individuals who went through the simulation-based mastery learning curriculum training, because the curriculum had been developed, validated, we had the checklist, we had all of the different elements, but of course you always want to learn, how can we make it better? Are there different aspects we need to be considering? And so we wanted to ask the nurses, the physicians, more about their experiences with central venous catheter insertion. So we asked them to think through what barriers and facilitators they identified, and we did this through qualitative interviews. So you may recall that you and I did many, many interviews together. And we were asking people to reflect on their current processes, and then we also asked them to reflect on their participation in the program. And we learned a few key aspects from that project that we've now been able to learn from and adapt into other projects that we've done. So for example, one aspect we heard was when we are looking to do the implementation of such a training program, we need to make sure that we're including the critical nursing perspectives. And we had been aware of and were including nurses that were working with the central venous catheter insertions. But what we really heard when we talked with some of these nurses was how important it is to consider the team-based safety culture, the ability of nurses to really be part of the creation of a program so that they felt that they could provide suggestions on it, that their voice would be heard in the same way that someone else's voice would be heard, that they could feel comfortable speaking up to either educate or even correct a physician's behavior. Something else we heard was the need for the creation of advanced modules that allowed for practice with simulators with variant anatomy. So for example, one suggestion we heard or comment that was made was that our simulators were all the same size. It was one particular simulator, but of course patients come in all shapes and sizes. So considering if there was a possibility of having simulators of different shapes and sizes, and the patient's anatomy may be somewhat different, and how valuable it could be for people to train on on models that weren't exactly the same.
And we actually took the